Our next speaker is Stacy Pinellas from UCLA.
Hi, and thank you to the panel for including me in this really fabulous section. So my case is a case of intermittent double vision. I have no financial disclosures. Okay, so we'll start with my 13-year-old patient who came in with horizontal double vision for 3 months. The double vision occurs for a few minutes at a time, occurring several times per day, but when she's not diplopic, she's fine. Her vision is fine. Her parents say the eyes look straight, but sometimes it looks like one eye's out, but they can't really put their finger on how the eyes look. Interestingly, she, and this may or may not be related, had a cerebellar medulloblastoma that was diagnosed and treated at 5 years of age with a resection, chemotherapy, and radiation. But she's had surveillance MRIs most recently 2 months ago, after the symptoms started, and there has been no recurrence. No meds, non-contributory family history. In terms of pertinent negatives here for this intermittent diplopia, it occurs throughout the day. It can happen right when she wakes up. It can happen when she's tired. It doesn't really have any sort of diurnal variation. It occurs whether she's looking up close or far away. She can't really pinpoint a distance where it's worse. She has never had any ptosis that she knows of. The double vision, when it occurs, is horizontal, and it's not on here, but it's binocular. It's never, if she closes one eye, it goes away immediately. And she never had any history of strabismus or patching during childhood. So we examine her, and surprise, she's not having double vision, so her exam is normal. And I really look. So if we think this is intermittent strabismus because she does have binocular diplopia, what else can we do? What would the panel do now in terms of examining her to try to bring out what's going on?
Keep moving her eyes.
Keep moving her eyes.
Yeah.
So I think you need to think of what's the differential diagnosis of diplopia that comes and goes. And we've already done myasthenia, so we know you weren't assigned that diagnosis, so we're not going to talk about that.
That would be pretty tricky.
Especially in a 13-year-old. So
it could be in a 13-year-old.
Right, so there are a few things. So everybody here was twitching about the ocular neuromyotonia, and so we're going to, and in order to bring that out, given that it's horizontal, you're going to try to make her look as far off to the abducting side as she can, and then we see if it freezes and sticks there, which is ocular neuromyotonia of the 6th cranial nerve from the radiation that she previously had, and it occurs years later. The two other things that just off the top of my head I would think about for intermittent diplopia, well, superior oblique myoclonus, that's intermittent oscillopsia, that little twitchy that you get. But sometimes, especially kids, even though it's very infrequent, they actually may recognize that as a double vision. And so in that case, you'd want them to look in the direction of the action of the 4th cranial nerves. And then the other thing that I've seen is kids who have Chiari malformations. And you can bring out divergence paresis or bilateral 6 by having them Valsalva or something, but typically they will have an esophoria at least on their exam when you see them.
And of course, I don't know if you've mentioned it on the first slide, just common things are common, just make sure the tumor didn't recur.
Right.
Yeah.
I think by far the commonest cause of this complaint outside of the ivory towers is a concomitant strabismus with varying levels of fusional control. So as a strabismologist, I would do a monocular occlusion test to try to bring out a concomitant deviation.
Yeah, we're simple people. So, yes, before we get
on us.
from Dr. Sikowski to me, we do the simple things first as strabismus surgeons and neuro-ophthalmologists. But wow, I'm really impressed by the panel's thought process already. First things first, let's think about the common things in this 13-year-old. We really have to think about an intermittent strabismus that is just, she happens to have a history of a brain tumor, but maybe she has intermittent exotropia, maybe she has a superior oblique palsy that she's maintaining fusion for most of the time. And so in my office, the first thing I would do is a 30-minute patch test to break up any fusion and then recheck her alignment. Look at up gaze. I didn't know there was a myasthenia case before this, so I thought we'd be discussing that. Is there fatigue? Is there ptosis? Is there a lid twitch? Certainly myasthenia is high in the differential in any case of intermittent diplopia. Her exam was normal, so a rest test wouldn't really work here because she would rest and then theoretically still be normal. And then looking at stereopsis in a child or an adult, because if a patient has a small, like a 2 or 4 prism diopters of esotropia that maybe you don't see on your exam, they won't have normal stereo. And then you look at their orthotropic exam and their lack of stereo, and you start to think about a very small deviation that perhaps you're not picking up on your cover testing. Okay, well, of course, we're a neuro sub day, and we have this excellent panel. So we have to think about the more rare things, and let's talk about the cranial radiation. So I want to show the exam after we did what the panel recommended. We asked the patient to look right and left and sustain her gaze. So here she is when she came in. I'm trying to find my arrow here. Well, on the top. She's orthotropic. I think the facial configuration makes her look a little exo, but she actually is ortho in all directions of gaze. Look to the left for 5 minutes, look to the right for a couple minutes, and then we were able to bring out her deviation. So after she looked to the right for a long time, she has an exotropia here. It improves in right gaze, and when she tries to look to the left, she has an adduction weakness that she didn't have before. So maybe someone on the panel, I know we discussed this a little bit, wants to help clarify what this is demonstrating.
Well, what's happening here is she's looking to the right, and you're making the sixth nerve fire a little bit more so that when the person then looks to the left, there's actually an adduction deficit of the right eye. So this is the extra firing of the sixth nerve, the so-called, again, the ocular neuromyotonia. Nobody really knows the mechanism. We sort of make it up. We call it a phaptic transmission. I don't really know what that means, other than sort of firing between, jumping between axons or something like that. But, and then after you rest the person, then after another minute or two, you won't see it. So it's brought on by moving the eye in the direction of the presumed paretic or abnormal cranial nerve.
Great, thank you. Anyone have anything to add there before I go on?
Somebody from the audience wanted to know, how urgent is it to do all of these things when somebody comes in and they have these intermittent symptoms? We get a lot of patients who come in with symptoms like this. Is it urgent to do these things? Can the person be watched?
Well, you want a diagnosis, right? So you do it in your office because you want a diagnosis, but none of the things, short of making sure you image to make sure there's no tumor recurrence, none of these things are life-threatening or vision-threatening, and you can refer for a consultation. You can figure it out, but I don't think any of this is very difficult to treat. So basically, you do behavioral things. You basically try to keep her from having her, in this case, her right eye in abduction for very long, because it'll make the sixth nerve fire more, and then you've got this lateral rectus holding onto that right eye and not letting it look in.
I have one guy who really likes his Tegretol.
Yeah.
He still has it on the Tegretol, but he has enough. He's a salesperson, and he's able to drive hundreds of miles a week, so he's quite happy that he doesn't have the double vision straight ahead. So you're right, though. Not everybody responds. Not everybody likes the side effects, but there are some medications that work.
And sometimes patients will have it combined with a cranial nerve palsy, and in those cases, they don't mind the neuromyotonia because it helps keep them straight.
Yeah, actually, in most cases, that's the case. So when you see these people, it's really cool because they have an esotropia, and then they look in the direction of the paretic sixth nerve, the paretic lateral rectus, and they develop an exotropia. And it's almost a little party trick that at least a couple of my patients, they're not as bothered by it, but they can show this trick that they do to resolve their chronic diplopia from their old sixth nerve palsies from the tumor.
Yeah, I think it is kind of a party trick. The most important thing in these cases is to figure out what's going on, because I've seen a few of these patients come in having seen many people and everyone's saying they're fine and then they're not really fine. And so it's sometimes validating for them just to know what's going on. So here are her measurements. As you see, after prolonged right gaze, she had a large exotropia in left gaze and even in primary and moderately sized exotropia. So a few words about ocular neuromyotonia. It's rare. As we mentioned, episodic double vision due to an involuntary tonic contraction of an extraocular muscle with delayed relaxation from the brief repetitive firing by the affected ocular motor nerve. The spasm are always triggered by sustained gaze in the direction of an affected muscle. It doesn't always follow radiation, but that's the most common, and it's typically associated with a history of paracellular or cellular tumors, but again, not necessary to make the diagnosis. Most frequently in the third nerve, but as in this case, it can also present in the sixth cranial nerve. Okay, so this is pretty esoteric. I wanted to have a few take-home points for those of you who, including myself, don't see ocular neuromyotonia every single day. The most common causes of intermittent strabismus are a decompensated phoria, a small tropia, or intermittent strabismus. In these cases, a patient would not be likely to have normal stereopsis, as a patient with ocular neuromyotonia might have when they're in their orthotropic phase. So do sensory tests to try to help tease this out, and you can patch them in the office and see if you can bring out strabismus. Myasthenia gravis is always on the differential when you have intermittent double vision. Again, you likely will have some ptosis and some fluctuation. It should improve after rest, but that's more commonly seen with ptosis and less common with diplopia. And then in older patients, distance esotropia or sagging eye syndrome, that's usually comitant, but it's worse at distance. So those patients may sometimes complain of intermittent double vision. So it's something else to consider in this sort of broad topic of intermittent double vision. And that's all I have. Thank you very much. Any comments from the panel?
We had a question for the audience. If there is no history of radiation, should we still be looking for this, or should we be looking for anything different?
I think, I may be mistaken, I think thyroid eye disease is also associated with ocular neuromyotonia. I don't know the
Yes.
mechanism.
It rarely can occur without an antecedent event, but very unusual.
You don't have to worry about a paraneoplastic event or something with this, if that's the question.
Let me ask a question related to this. This was a 13-year-old with this history of tumor. How about the patient who comes in, our normal patient who's like 70 years old with intermittent episodes of double vision, and you don't see anything on the exam? How are you thinking about that? What are you doing to manage? They've had 3 episodes in the last 4 months. How are you handling those patients?
Mm-hmm. Yeah, so I, like you said, I just sort of categorize that as the adult with double vision but a normal exam, and I'll probably send off a receptor antibody and see him in 3 months. That's about it.
Well, I would ask about giant cell arteritis symptoms and get a CBC sed rate and CRP as well. I mean, we all know that up to 60% of patients who have vision loss from giant cell arteritis, if you actually ask them in the prior week or so, they've had episodes of either transient monocular vision loss or transient diplopia. And so we never seem to get it prospectively from that direction. And so if this has been something that's been going on just the past week, that's when I get worried. If, as Grant says, it's something going on for months and months, I get much less concerned.
I would say, again, the patch test, latent deviations decompensate with time. This is a big majority of them.
One last question. In this particular case here, would an MRI be helpful? Other than looking for recurrence of the tumor, is there any other reason you'd want to get an MRI?
No.